Hello, everyone. I'm Trish Grooms. I'm a licensed master social worker. I hope everyone is doing well, staying safe and healthy in the middle of COVID-19 and the chaos of 2020. I would like to share a little bit about myself before we go into the webinar. I'm a counselor at Texas School for the Deaf, and I've been working with students for over 20 years. Prior to that, I have worked in a variety of mental health and human service agencies for many years, providing supports to deaf and hard of hearing population. I am profoundly deaf. I was adopted and grew up as the only deaf child in a hearing, non-signing family. I graduated from Texas State University in San Marcos, Texas, with both a bachelor's and master's degree in social work. I'm excited to be here today to share with you this webinar involving clinical suicide assessments with deaf and hard of hearing students. However, I want you to know that this webinar is specifically geared towards those who have licensed clinical or masters in social work, licensed professional counselors or LPCs, and LSSPs, licensed specialists in school psychology, and other mental health professionals. This webinar will focus mostly on acquiring information from students who are deaf or hard of hearing to determine the need regarding safety, hospitalization, and a possible referral to a clinical suicide assessment. However, it's important to also identify the need for a clinical level assessment after a basic suicide screening. Even though most of us already know most of the common factors and behaviors that could indicate the need for a clinical assessment, it doesn't hurt for us to go ahead and review this. Risk factors. These are variables that signal the need to look for warning signs of suicidal thinking. Psychopathology, which is prior suicidal behavior, which is the best predictor. Substance abuse can also act as a trigger and increases vulnerability. Psychopathology is associated with about 90% of suicides, and that's why it is imperative that we ask questions regarding previous attempts or ideations. Family, including history, stressors, and functioning. For example, there may be a history of domestic violence, a history of alcohol use, perhaps cancer, other stressors in the family. Stressors can include loss of family members, COVID-19, for example. Some other examples of stressors, such as the way in which the family functions. Perhaps it's a single-parent family, or other incidents have occurred in the family that can be risk factors. Situational, such as a disciplinary crisis. That is one of the most common with students who have a suicide outcry. If there is a consequence and they don't want to accept it, that can lead to that. Also bullying, breakup with a romantic partner, lack of coping skills, loss of a friend, and others. Biological is also a risk factor. This can include things such as a low level of serotonin. Serotonin in the brain is thought to regulate anxiety, happiness, and moods. Low levels of serotonin can lead to depression, mood swings, high anxiety, and/or insomnia. So those are risk factors. Now for warning signs. These tend to be variables that signal the possible presence of suicidal thinking. For example, suicide notes, both direct and indirect suicidal threats or statements, social withdrawal and isolation, heavy use of alcohol and or drugs, loss of interest in activities they normally were involved in, giving away prized possessions, making final arrangements, talking about death, despairing attitude, low academic performance, changes in relationships, abrupt changes in appearance, inability to concentrate or think rationally, sudden unexpected happiness, low level of self-esteem, increased irritability or crying easily, lack of sleep or sleeping excessively, and sudden appetite changes. All of those are considered warning signs. It's important to also know protective factors, which are behaviors that should also be considered. For example, do they have good coping skills? Do they have a good support system? Do they have problem-solving skills? Positive relationships? Positive connection to school? Or good impulse control? Those are also considered important questions. The more warning signs this student has, or specific serious warning signs that a student has in addition to risk factors, and yet not enough protective factors, really calls for immediate clinical assessment and intervention, as the student is considered at high risk for suicide. For example, let's say you have a student with minimal language. Maybe they have some difficulties at home. Maybe they don't have access to communication there. Versus another student who has a positive relationship with their family. They're involved at school. When looking at the two at face value and consider which one is at more risk, probably the first student, because they may have a lack of support. However, if you were to take both students and both wrote a suicide note, both are considered at high risk regardless, because their safety is paramount. So you have to consider their background and helping you through that process as part of your clinical assessment. Basically, the goal of clinical assessment is to determine the level of safety the student can or cannot maintain. Do they need a hospitalization or psychiatric care to help? And what sort of referral may need to be made for support, such as counseling, a support group, or other resources? Remember the limits of support groups and resources for deaf and hard of hearing. For example, access to communication within a support group is a big one. But also, the people in that support group are not as likely to have the similar experiences of a deaf individual. The vast majority of the participants will be hearing, which can be important in that healing process for a deaf student. It can be extremely difficult to access resources, even more so with COVID-19. Acquiring information for a student for the clinical assessment at times can be difficult. It can be emotional, frustrating, fearful, anxious, and draining for both the student and the assessor. So it is critical for us to ensure that we remain calm, show empathy, respect, patience, and warmth. Meanwhile, it's also important for the assessor to be aware of various possible issues or barriers, as well as the importance of the process itself. If you remember back in our college days, when we took child development classes, we had to familiarize ourselves with the different typical stages of development in children in order to recognize concerns or delayed developmental issues in various areas. That's important to keep in mind while assessing students. When assessing students for suicide or threats or ideation, that's also other factors to be mindful of: a student's biological age versus their developmental age. For example, you may have a child who's 13 years old with an intellectual delay and could be developmentally at a slower rate, and they may be at a certain intellectual capacity. You need to also be conscious of typically developing children with language delays or socially delayed. Knowing this type of information will certainly impact how you will communicate and acquire critical information, as well as make clinical decisions based on other factors and such. With deaf students and deaf students with additional disabilities, the ability to communicate is vital when assessing students who may be suicidal or in need of crisis intervention. When we're able to communicate effectively, the process can help the student become calm and/or less frustrated or scared, as well as create a connection between the assessor and the student. When you're demonstrating that you're okay with whatever the student may share, and you're not afraid to discuss suicide itself, then you're able to create a safe space where the student is able to trust you enough to share their struggles. It's important to convey reassurance through verbal or signed and nonverbal communication. For example, maintaining eye contact, your tone, facial expressions, and the like. From my experience with deaf students that are in crisis mode, they are much more hypervigilant in picking up the vibes that may be created, and that could cause to distrust or misunderstanding or even misinterpret your facial expressions. So that is critical for you to maintain a calm and neutral demeanor as possible with your facial expressions until you're able to develop that rapport. During a suicide assessment, confidentiality is no longer the priority, especially if a student is at high risk. Their safety and their ability to keep themselves safe is now the priority. The assessor may also need some additional support during the process as well, in getting things such as food, reaching out to specific individuals. For example, a nurse may need to come to look over the child if there's been any cutting or self-injurious behavior. An administrator may need to be involved. Students who are suicidal need to be made aware that at some point their parents will have to be notified, as well as why. As well as sharing that some staff or teachers in the school may need to be aware in order to closely monitor the student for the following few days, as well as check in with the student. Really, this process is dependent upon your school district. But bottom line is, the higher the risk, the more people that will need to be involved. Confidentiality does not mean that you're just sharing with anyone what was in the interview itself, but it's important if there's specific triggers or suicidal thoughts, those are important to share. But other things, for example, perhaps the child talks about their mom has been mean to them, that's not information that needs to be shared with mom. You can keep it superficial and just mention there are some issues in the family. We don't want to hurt the healing process. It's important to be very mindful of what we share, but things such as triggers or suicidal statement, those can't be kept confidential. During the process, it's imperative to take a non-punitive approach and be consistently patient. This is not the time to discipline, belittle, or embarrass the student, regardless of how many times the student has threatened suicide. Do not argue, It's unnecessary. Otherwise, you're going to lose that connection and end up having to deal with a non-cooperative student that does not trust you or the process itself. That being said, the need to be patient, calm, neutral, direct, respectful, and empathetic is crucial and can be beneficial in acquiring the information needed to determine what sorts of interventions or supports may be needed by the student. You may have a student who threatens suicide every time they're in trouble or does not accept the consequences for their actions whenever they're trying to avoid a situation. If that is the case, that should be an indication this student may not have good coping skills. They may struggle with managing their emotions and/or impulse control. And those should be addressed. However, it could also indicate various risk factors and lack of protective factors as well. Be mindful of any warning signs also. Be direct and curious. Curiosity is your best tool, and it can guide your questions. For example, how do you experience your suicidal thoughts? What kind of physical experiences do you have related with those? What time of day do you feel them the most? Don't be afraid to ask the quote-unquote S question. Ask with confidence. And ask the most important question of all. Are you thinking about killing yourself? Use open body language. Use supportive and encouraging comments. Now, suppose you have a student who is not cooperative or exhibiting uncooperative behaviors. For example, refusal, not saying anything, ignoring you, perhaps refusing to respond to questions, maybe trying to rush the process, or maybe it's reaching lunchtime and they're saying, hurry up, I want to go to lunch. Also, refusal to participate in the crisis safety plan, trying to leave the room without completing the assessment. What do we do in those situations? First and foremost, remain a calm and direct manner. If they're ignoring you, you could wait it out. You could even slide a piece of paper and pencil under their arms if they have their head down. Let them look at it. Be direct in explaining the expectation of the assessment. Continue to say that you want them to be safe and you want to help keep them safe. Sometimes you may have to say, school policy or school regulations require you to do this, and you have to follow through and have no choice. Keep your statement short. Being patient will be your number one virtue in this process when a student is not cooperative, meaning you have to have a good deal of patience within this sort of situation. I know for me, I've had this experience from time to time, and typically when I'm called for an assessment, I'm oftentimes thinking to myself over and over, trying to practice through the process. Anytime I have those thoughts of, more paperwork, or, I have to do this is the wrong time. Any of those kinds of thoughts can create a barrier in communicating and going through the process of the assessment. So whenever I replace those thoughts with thoughts of patience, concern, and wonder, I find myself more successful. So now, when do we call mental health deputies or 911? Of course, if a student is in the middle of carrying out a suicide plan or injuring themselves, if they have a knife or other means, call 911 right away. You will need to call 911 or the mental health deputies when the student has a plan, method or access to a way to carry out that method. You'll also need to reach out to the parents and notify them so they are aware of the situation and where they may need to go to meet their child if they are on their way to the hospital. If parents refuse medical attention, for example, with the mental health deputies with their child, it's important to still have the parents come and pick up their children and sign an agreement that they will get doctor's notes saying that the doctor is cleared and safe to come back to school. The child's safety is number one. When a student is not cooperative and they still haven't shown that they can be safe after working with them or talking through it or asking questions, perhaps refusal to participate or respond or be a part of the crisis safety plan, I strongly encourage you to call the mental health deputies and parents both. It is vital that the student can be safe and keep themselves safe. These behaviors are also indicators of underlying issues or factors, such as fear, shame, or others that are hidden by anger. When the mental health deputies are contacted, we need to remember to remind them to request accommodations for access to communication, such as interpreters, a certified deaf interpreter, clear access to lip reading, or whatever accommodation may be necessary for the student. Be sure to include that. With the pandemic of COVID-19, communication access is an even deeper struggle for many, as there tends to be additional barriers and fear due to masks or removal of masks, shields, when they don't want to remove those for communication, which can belabor communication even further. Also, services in general have become more limited or restricted. So if at all possible, assist in providing additional supports.